Hello, Assalamualaikum warahmatullahi wabarakatuh, and a very good morning, students. Today we're going to learn about the next topic, which is peripheral arterial disease. This time around, I'm doing a pre-recorded session so that you can settle down with your moving into your college. Basically, this topic, PAD, is supposed to be scheduled on Wednesday, but I swapped it to Monday today. And then the Monday's topic, which is ischemic heart disease, will have a live lecture on Wednesday. Okay, so I hope you're okay with that. Okay. So at the end of this class, you should be able to know the definition of PAD, the risk factors of PAD. So when I say PAD, it's actually peripheral arterial disease. Yeah. Okay. You should be able to know how to calculate the ankle brachial index and how to manage PAD, either with non-pharmacological and with pharmacological intervention. So this is the outline of my lecture today. We'll be covering some key concepts for this topic: the definition of PAD, the epidemiology, pathophysiology, symptoms, diagnosis, and treatment. So as the first part of the lecture, I would like to highlight some of the key concepts with regards to this topic. The prevalence of PAD is related to age and the presence of atherosclerotic risk factors for cardiovascular disease. Despite the significant morbidity and mortality, PAD awareness remains low, resulting in many undiagnosed and untreated patients. The clinical presentation of PAD is variable and it includes a range of symptoms. The two most common characteristics of PAD are intermittent claudication and pain at rest in the lower extremities. So throughout the lecture, later on, I'll explain what intermittent claudication means. The ABI, the ankle brachial index, is a simple, non-invasive quantitative test that is a highly sensitive and specific tool to diagnose PAD. Several atherosclerotic risk factors plays an important role in the development and progression of PAD, and many of these risk factors are modifiable using various non-pharmacologic and pharmacological interventions. So, for example, some of your non-pharmacological interventions are like supervised exercise program, and these can improve a patient's quality of life and reduce leg symptoms. In terms of pharmacological therapy, we have antiplatelet therapy such as your aspirin or your clopidogrel. These are recommended to reduce myocardial infarction, stroke, and vascular death in patients with PAD. In addition to exercise therapy and risk factor modification, there's another agent called sildenafil. So it is an effective medication to reduce leg symptoms and increase walking distance in patients with intermittent claudication. So let's move on. So as you can see this picture, this is an example of patients with PAD. So it looks like somewhere between your gangrene from your diabetic foot ulcer, but it's actually not. This is peripheral arterial disease. Yeah, where you can see those ulceration at your big toe or at your sole. So this is quite sad for patients who are experiencing this disease. So some definitions that you need to know. Okay, PAD is a generic term that encompasses vascular insufficiency in your non-coronary arteries. So bear in mind, you need to pay attention. This is your non-coronary arteries secondary to atherosclerotic occlusion. So you have this blockage here in your non-coronary arteries due to this atherosclerotic occlusion. So we kind of say like PED is like a heart attack, but it's not at your heart, it's actually at your vascular system. So but the source of occlusion is your atherosclerosis. That's why we said it's almost similar like your heart attack, but it's not at your heart, it's actually at your leg. So when you have this occlusion, there is blood supply to the lower part of your legs will be low, and hence that's why you see all those gangrene and all those ulcers happening in patients with PAD. Now it could be the arteries that are affected, they supply blood flow to the brain, visceral organs and limbs. So there's two types of PED. There's functional, which is caused by spasm in the vessel, example like the Raynaud's disease, or organic cause, which is due to structural changes in your blood vessels. For example, fatty build up in the arteries. So in most of the time, it's due to this organic cause. So in terms of epidemiology, in North America and Europe, there are about 27 million people affected by the disease. Around 10.5 million people are symptomatic, and the rest are asymptomatic. And the incidence increase with age, affecting about 20% of patients older than 70 years. So it's something like your heart attack as well. The incidence increase with age, especially the elderly. So here's a diagram that I obtained from American Heart Association. As you can see here, PED, it correlates with your coronary artery disease and your CBVD. As you can see, about 61% of patients with PED, they also has coronary artery disease with or without cardiovascular disease, 61%. So 18.3% patients with risk factors and no disease has PED as well. So the pathophysiology, I hope you you've been watching some of the videos that I gave in your pre-class activity, or else you can also watch this YouTube to have a feeling of what the pathophysiology of PED. Now, looking at the symptoms, patients may be initially asymptomatic, meaning they don't have the symptoms in the beginning, but then they progress to this term called intermittent claudication and possibly critical leg ischemia. So the pictures, the very bad pictures that you've seen in the beginning, those are patients who are having severe symptoms of PED, like your critical leg ischemia. Now in this slide, I've actually showed some similarities and differences between PED and DVT, because both problems are related to your leg, especially patients complain of pain at the lower extremities of your leg. But as you can see here in the left part of your slide, that shows patients with PAD, and the right side is patients with DVT. Like I said, both will complain. Both patients will complain pain in the leg, but however, in PAD, what's distinct between PAD and DVT is that in PAD, your legs, they get tired when you're doing activity, but then when you're having rest, it will kind of improve. But in DVT, this distinct features doesn't happen in patients with DVT. Patients with DVT, they will complain of pain and tenderness, warm and swelling throughout the time, the whole period that they're having the DVT. And then and in PAD you also have wounds that sometimes they don't heal, like you see in the picture, in the earlier picture. So whereas in a DVT you don't have these broken wounds. You have pain. It's patients will complain of pain, and you have swelling, warm, and redness in DVT. Okay, and if it's still unclear of whether it's PAD or DVT, they will order some tests to ensure that the diagnosis is correct. So the next picture also shows you again the differences between PAD and DVT. Like I said, the main difference is actually in DVT you have a blood clot in your leg, whereas in PAD you have clot as well, but it's due to your atherosclerotic plaque. So like I said, it's something like a heart attack, but it's actually at your leg instead of your heart. How do you diagnose patients with PAD? Like I said, once the physician or the doctor suspect that the patient has PAD, especially in those with risk factors like age and atherosclerotic plaque, patients with underlying coronary artery disease, so they will order this diagnostic test called the ankle breaker index, or the ABI. It's actually what you actually do is you actually take your blood pressure measured in both arms and ankles using a regular blood pressure cuff and Doppler. So these two measures are then compared, and a determination is made on how adequate the blood flow is. The specific index of reference number is determined by dividing your ankle systolic pressure by your arm systolic pressure. It can be done with or without a treadmill. I'll show you exactly what I meant. So actually you have, like I said, you have you measure your pressures in your right foot, okay, and then you measure the pressure in your arm. So what you do is you divide the foot with the arm, the pressure with the foot and the pressure with the arm. So how do you interpret the ABI readings? So when you have a reading of between 1 to 1.4, that's normal. When you have a reading of 0.9 to 0.99, that's borderline. However, when your ABI reading is below than 0.9, then you have an abnormal ABI, and hence it will most probably lead to the diagnosis of PAD. So here's another a diagram on how you want to measure your ABI. So you can actually measure it in both arms, okay, like you see in the one in green, okay. So you have your right arm pressure of 110 and your left arm pressure of 140, whereby again you measure the pressure of both right and left ankle pressure. So you actually take the pressure from your ankle, okay, which is 105, and divided by your pressures from the arm, which is the higher one. So between 110 to 140, of course 140 is higher, so then you divide those and you get 0.75. So remember what the reading I said just now. If it's less than 0.9, then it's highly likely that the patient has PAD, right? Okay, unlike the one with the red circle, as you can see, there's only one measurement of the right arm pressure. So when there's only one, you get 0.96. Yeah, 105 divided by 110, you get 0.96. So that's actually a false negative result, whereby anything less than 0.9 is considered a diagnosis of PED, but in this calculation, when you get 0.96, it's actually normal, but whereas in reality it's not normal. Okay, see here. Alright, so this is actually again how you want to measure and calculate your ABI. Okay, so basically it's like it's using this your blood pressure cuff at the arms and at the legs. It's actually quite simple. Okay, now looking at the risk factors, who are actually at risk of getting this PED? Like I said in the beginning, so those who are age older than 50 years old, they are at risk. Okay, those who have family history of PED, those with high cholesterol, okay, hypertension, coronary artery disease, stroke, cigarette smoking, and diabetes. So these are like your normal cardiovascular risk factors that a normal patient would have. Like I said, in 2015, Quickly et al. Had published a paper looking at the risk factors for PED. As you can see, smoking and diabetes is the highest risk factors for PED. So smoking is actually a very important risk factor for patients with PED. Okay, as you can see, those in yellow, current smokers, are quite actually high. Yeah, meaning if you the odds of getting a PED when you're a current smoker is about 2.8. So it's quite significant. Yeah, and a history of CVD, as you can see at the top here. Here's a history of cardiovascular disease, and here's a current smoker. Now, so once you already identified the risk factors and then you've calculated the ABI and it's confirmed that patient has PED, we will need to start treatment. So in general, the treatment looks at diet modification, exercise, smoking cessation, and this is applicable to all forms of tobacco. So whether the patient is vaping or smoking or whatever, we have to emphasize them to stop smoking. So it's the single most important intervention, and people who smoke are given a diagnosis of PED as much as 10 years before a non-smoker. Okay, once you have addressed all those non-pharmacological intervention, you can start giving drug therapy. So what drugs you want to give to this patient is actually the same with your cardiovascular disease. So in patients who have high cholesterol level, you want to initiate statin with the goal of LDL-C of less than 1.8 in patients deemed very high risk. Okay, and those with high total cholesterol, you can also give high triglyceride. You can give fibric acid agents. Yeah. Of course, patients with underlying hypertension, you would need to treat the patients with antihypertensive, okay, with the goal BP of less than 140/90 if they're non-diabetic, or less than 130/80 if they're diabetic. So you can either use a beta blockers or an ACE inhibitors. Now, in patients who have diabetes, of course, you need to emphasize on proper food care with the goal HbA1c of less than 7%. And antiplatelet is recommended for all patients with lower extremity disease. You can either use aspirin, clopidogrel. However, warfarin is not indicated. So when you have claudication, that means when you have pain during exercise or during activity, the agent of choice would be your silastazole. Okay, it's a phosphodiesterase type 3 inhibitor. It causes an increase in cyclic adenosine monophosphate and has a vasodilatory as well as antiplatelet effect. Okay, the precise mechanism in claudication is unknown. You can give it 100 milligram twice daily, and this agent improves symptoms and increase walking distance. However, you need to avoid using silastazole in patients with heart failure. Please take note of this point. Okay, apart from that, we also have another agent called pentoxifylline, or the brand name is Trental. It's a methyl-xanthine derivative. It reduces blood and plasma viscosity and hence inhibit neutrophil adhesion and activation, increase erythrocyte and leukocyte deformability, and lowers plasma fibrinogen level. You can give it 400 milligram 3 times a day, and this is a second line agent, and it has a questionable efficacy. Okay, that means if we've already started with silastazole and it's not working, then it's good to give it a shot with this pentoxifylline. Now we also have this interventional radiology. Okay, it's reserved for patients with lifestyle limiting symptoms, and it may include doing angioplasty or stents at the blocked vein. Okay, now when the patient has critical limb ischemia, okay, you can either use pentoxifylline, oral vasodilator, prostaglandin like your Birapros or Ilapros. You can either use do endovascular treatment, thrombolysis, or surgeries. Okay. Now here's the ESC guideline with the recommendation in patients with PED. Like I said, the best medical therapy, the best thing is smoking cessation. It has a class 1B level of evidence. Healthy diet, physical activity are recommended. Statins, okay, in patients with PED, it's recommended to reduce LDL-C to less than 1.8 or decrease it by 50% of baseline. In diabetic patients with PED, we have to emphasize strict glycemic control. Antiplatelet therapy is recommended in patients with symptomatic PED. Yeah, in patients with PED and hypertension, it's recommended to control BP of less than 140/90. ACE or ARB should be considered as first-line therapy in patients with PED and hypertension. That's a class 2AB evidence. So I think before we end our lecture, I'll just give you a case. Okay, so we have CJ. It's a 56-year-old man, presents to the primary care provider office for a follow-up visit after his evaluation of possible PED. His medical history includes hypertension, and he's a smoker, current smoker, 2 packs per day for 20 years. His ABI comes back at 0.06 from these results, which are the following best classified CJ's PED. So have a think what the answer is, and remember what we said just now. So does the patient has normal borderline, abnormal, or non-compressible? So we'll discuss this in the next lecture. Okay, so these are my references. With that, I thank you.